Dr. Folio is a senior research physician and the lead computed tomography radiologist at NIH Clinical Center. He will provide an overview of our Radiology Preprocessing (RP) integrated workflow curriculum that includes image acquisition such as computed tomography or CT and PACS, otherwise known as Picture Archiving and Communication Systems. PACS is used to view medical images and includes highly advanced processing tools that produce multiplanar reformation, 3D imaging, and lesion management applications.
And now we'll walk into the CT consult area. So now we're in the CT consult or consult reading area where we've got our workstation, very powerful. They don't all have to be this powerful, but this is fairly typical. So for the RP course, Radiology Preprocessing course, you're here now. This is the part. The modality overview talks about other modalities besides CT, talks about X-ray, nuclear medicine, ultrasound, and then the PACS is the picture archiving communication systems, which is what we're looking at here, which I usually start with the bone window. In a big picture, as if I'm looking at the patient, you can see a little right marker here. So it's as if we're looking at the patient. I can get a big picture of their spine. They've got a little lateral curvature here. And go to sagittal, and so now we're going through the 3D data of the person here, and so we can see the hips, and now the spine comes into view. We can see a little defect here to the posterior vertebral spine, not a big issue, but then we go to the ribs, and so the ribs are kind of in section here, so I go to a multiplanar. You're going to see these come back, but if you focus on this one window, then I can tilt this to the ribs. So now I'm tilting along the ribs. I can put them in the thick mode. It's a little bit, since they have a little bit of lateral curvature, I'm going to tilt them more in plane like this. And I'll bring this back. So now I can get a big picture of the clavicles, each of the ribs along their axis. Then I put it into a regular view, and this helps to scan a little bit as far as looking at ribs. Going up and down, and you can see where the contrast went in here. Here's the humerus and the scapula. And you'll note that I'm scrolling with the keyboard here that has a roller ball. So when I go into lung window level, we're still using the sharp algorithm. Then I'm using the foot pedal and I'm gently scrolling through because this is a lot better than trying to scroll with a mouse. And here, while looking at the lungs, we're looking at the detail. I didn't see any large nodules, but there was a little bit of nodularity, mucosal thickening back here. So I'm comparing two different dates, and I can see and compare this thickness a little bit better. Now we can go into the view, get into a little more detail. We generally look at everything in a 2x1 overlapping thin, 2x1 millimeters overlapping. So starting from the top, now we've gone through the lungs, we've gone through the bones. So now I'm looking at thyroid, making sure that's all symmetrical. You can see the lymphadenopathy. Here's the aorta, pulmonary arteries. So the first thing that we have, first thing I do and the first thing radiology preprocessors do is look at the pulmonary arteries to make sure there's no pulmonary embolus. Making sure the pulmonary arteries don't have filling defects in them. And we look at each vessel on both sides, and here's what they look like in the coronal. This is the chest, abdomen, pelvis. So basically, we're looking at all of these blood vessels. I can put it into a multiplanar volume rendered and then make this a little bit more obvious as to what we're looking at. These are the blood vessels. So all this data is here at all times. We're just electing to look at it in this particular window. This is how we do most of our scrolling. So now going back, I see there's no pulmonary embolus. Looking at the axilla, obvious adenopathy here. Very similar to where it was last time. Yeah, a little bit smaller. We'll go over that in a second. And I see a hilar adenopathy here, these nodes. Then coming down through the heart, aorta, and the pulmonary arteries here, we've already looked at. Then continuing inferiorly, we've got the diaphragm, then now into the liver. So I start with liver, go through the entire liver carefully. There's a little bit of fat sparing, or a little bit of fatty infiltration here that's common near the falciform ligament, which is right here, divides left and right lobes of the liver. Then look at the adrenal glands, the right adrenal gland, then the right kidney. Come down, you can see the ureter here, collecting system. Then I come back up, down, bottom of the left kidney, coming up into the left adrenal here, left adrenal there. Here's the stomach. I look at the spleen, go through the entire spleen. Now the spleen is a little bit large. We'll look at that in a second. Then I start with the tail of the pancreas and come around to the head. It's a little bit harder to see the head of the pancreas sometimes, but this one's outlined pretty nicely, and all the vasculature. So then we look at the vasculature here in the center. This is aorta as it came down. So here, let me just put that in a big view here to see the vessels. I'll just change this window and level a little bit. So what we're looking at now, kind of drill down into the vessels, is that aorta. I can put it into a sagittal view. So here's how the aorta came out of the heart and it's coming down. So we're just going through and looking at that tube as we go down into the iliacs. And then when it's in the iliacs, we pretty much, then here's the aorta dividing into right and left iliac arteries, and we're looking at all this. This is just a 3D view of all the musculature and the vasculature. So let's go back. And by the way, these windows that I'm changing, this is the soft tissue window level. This is a lung window, although it's not the lung algorithm. It's not as sharp as what we see over there, so we use that for that. And this is the bone. But now we're on soft, and we're looking at, so we left off in the spleen. Notice that's enlarged. We finished with the pancreas. We're looking at aortas where I left off, and here's the vena cava. So vena cava and aorta, looking for any vascular abnormalities. And then I pick one side and I keep following that all the way down. I'm seeing the adenopathy over here. I'm disregarding that because I'm right now on the vessels. That's just a flow artifact right there. Coming in now back to the other side, the opposite, the left iliac, branching into external and internal. Here's external, little tiny node there. Big node here, that's adenopathy. And then these are already measured, so I don't have to think too much about those because that's a time-consuming task. So I'll show you what happens with that next. Okay, so the spleen's enlarged. I can show you that here. It shouldn't be almost the size of the liver. Here you can see they measured this in elongated fashion, and it's certainly enlarged. In fact, what we did is we did a splenic volume on this, and here you can see it outlined in red, so that's been segmented, so we don't have to do that. So that's the splenic enlargement, and they're actually looking at volumetrics of the spleen, and we can rotate all that around. And what the radiology preprocessors are doing is doing this in the background, where the machine didn't quite catch this because it's so small, it doesn't believe it's the same one. So we're thinking like the computer. So now we've got it where we can see this adenopathy is much smaller, and then these two can then make up a graph. The spleen was big before, and now is small, and this lesion is smaller here in the spleen. So I'm hitting a shortcut to say jump to this lesion, and now I'm doing a visual quick comparison of that adenopathy. So then I can go down here and look at this adenopathy there. So both of these are enlarged. Let's look at this one. And it's not followed up, so I break the registration, come into that one. Look at that. It's so much smaller, it's hard to find. It's like disappeared right here. So then measure it again and then see if it picks up on it, because they're registered, meaning over time they're co-registered. Then to compare these, this puts it into the data. So every time we're jumping to a different part of the bookmark list. Then if these are targets, each one that's specified, then I can take these and make them into targets. And this is done by the oncologist. And this is the tumor part, the tumor measurement, the clinical trials part of the study. So now we can go to the table, and then we can look and follow these lesions and graph them over time, which I've only got one really as a target and specified and matched the same way. But that's where that comes in handy. So now that we've covered that, we'll have a chance for questions and answers with myself and with my IRTA, or Intramural Research Training Assistant, Jane Dimperio.
Hi, my name is Jane Dimperio, and I am a current radiology preprocessor, otherwise known as RP, working with Dr. Folio as a postdoc IRTA. I graduated from the University of Pittsburgh in the spring of 2020, and am currently working as an RP during my gap year before beginning medical school this summer. Because of the COVID-19 pandemic, I'm working remotely instead of working on site with Dr. Folio in Bethesda.
Dr. Folio, was it challenging finding collaborators willing to provide presentations given how busy medical centers have become?
No, actually, it was more challenging to control the enthusiasm. It was around Thanksgiving time frame. I had some time on my hands and reached out to a few centers saying I want to start this radiology preprocessor course, or at least make what we have at NIH available online, publicly available. And folks were coming out of the woodwork. I reached in a little bit, such as Dr. Marilyn Siegel from Mallinckrodt Institute of Radiology with Washington University School of Medicine, she's presented on cancer immunotherapy and has a presentation on new challenges in imaging, for example. And Dr. Christoph Becker from Stanford University heads up the core lab there. Said I'll present something on a basic overview of clinical trials and RECIST and the history of how these quantification labs emerged and the criteria. Also, Dana-Farber Cancer Center with Harvard Hospitals Medical Centers in Boston. In fact, the four of us have been teaching courses for RSNA, Radiologic Society of North America, our largest international radiology society. We've been teaching these types of courses there for years, as well as Society of Advanced Body Imaging. The name just changed from Society of Computed Body Tomography. Now it's SABI, or Society of Advanced Body Imaging. And other centers such as University of Utah, Dr. Sherry Wang has excellent presentations on MR anatomy and other nice video presentations. And also engineers from University of Oxford in England, such as VGG, VIA, annotator tools, ITK Snap from the engineers at University of Penn. So no, it's not been a challenging. Anyone we've asked has said yes, and it's more trying to curb our enthusiasm, not trying to expand too fast. So we're manageable, and I think a fairly comprehensive course with collaborators just offering to give their presentations and make them publicly available.
Jane, walk us through your experience in the training process.
Sure. So initial training involves familiarizing oneself with CT anatomy and pathology through presentations and quizzes, but the bulk of training involves getting comfortable with image processing or preparing annotation data on CT exams and learning what is important to measure or otherwise point out. I've now processed over 300 CT scans, and I'm still learning and improving every day. As with any new role, there's definitely a learning curve, especially at first, but looking back at how much I've learned in such a short amount of time is a really great feeling. And there's also motivation to be accurate and fast, similar to how radiologists have to practice.
Dr. Folio, what do you mean by human-driven AI workflow? And is this what you believe is the next step where AI will be assisting radiologists to improve their interpretation of images and resultant radiology reports?
Well, there's three generally agreed upon areas where AI is going to augment radiologists or the field of radiology in general. The first is workless triage. So if Jane is going through the work list and it's say 9 in the morning and I'm already starting to get behind, she's already reviewing exams that I'm not getting to maybe 10 or 15 minutes ahead of time. And since radiology preprocessors are taught to detect or identify incidental findings that are potentially critical, something they haven't, or if it's something unusual and they haven't learned in their program, then she can send me a text and say, or call and say, you may want to look at this one next. And I think it's a pleural effusion or a pneumothorax or a pulmonary embolus, for example. So workless triage is something where AI has already started to augment radiologists. And this is the type of workflow radiologists will start getting used to. So the human-driven component that's Jane helping the automation that we have. Although most of the automation I've been using for the last 4 or 5 years is mostly computer-aided detection and registration. Some of the tools we've gone over in the packs that we use, and other packs and other systems that you can see on our website have implemented different parts of this, and some are up to 90% of detection or things for the radiologist to actually help them in the diagnosis. And in addition to the workless triage, which I think is the most important and potentially life-saving, the second thing AI is going to help us with, and it's generally agreed upon, is the identifying of abnormalities in clinical trials, especially target lesions. And that's where the radiology preprocessing program comes from. The name preprocessing meaning processing the images before the radiologist opens it, as opposed to most workflows, including a lot of what we do at NIH Clinical Center, is radiologists dictate the exams. Then the clinical trials will take our dictations and the images, identify the targets, then calculate the response, which you can learn about in some of the other presentations. So identifying metastatic lesions, and more so the target lesions, which Jane knows how to do, it's in the training. We can look in the bookmark table, see which ones are the target lesions, identifying those, measuring those. I import them in my report. I am pretty much overseeing the work. I'm still doing the same interpretation I usually do, but faster, because I don't have to go and measure those, as you saw with the packs. It takes time to do that. So identifying them and measuring them for consistency. And lastly, collaborative reporting, which we integrate with the radiology preprocessors, and that's described in one of the presentations, where there's collaborative reporting similar to residents reading exams and learning. They're actually dictating now, they're producing a report. And then we then get that report, we look at the images, and then we look at the report, see if that report is accurate. That's a different and parallel workflow. The two don't mix, at least not at NIH. So the collaborative reporting that we all radiologists grow up with in our residency training, we're always working with a radiologist professor that's teaching us. And similar in radiology preprocessing, where the students of radiology, which can be technologists or college graduates like Jane going to medical school next year, or medical students, whatever the case might be, this collaborative reporting not only keeps it more interesting, it's active learning on radiology preprocessor perspective. Every time a read is done, there's a back and forth in a collaborative environment. We can use shared drives and do it all remotely, where there's feedback. As soon as I'm done the exam, then I put in how many misses there were, or good job on this. So each exam is graded, just like a radiologist would be overseeing a resident's workflow. And in private practice, this is really taking off, where some private practices are using up to 6 radiology preprocessors, or sometimes they call them scribes. And they're trained to prepare the data for the radiologist, such as ultrasound measurements, and getting them ready to import into the report, and them not having to think about that, where the radiologist is just focused on that final report, saying that report reflects everything that's in these images, and signs off on that. But the more preparation, the better. So the human guided AI, or the human driven AI, I think is going to continue for a while personally. And we've been doing that now for 4 or 5 years at NIH, where we have radiology preprocessors preparing the data, looking for incidental findings. It's turned around our reports hours quicker. We notify the providing docs sooner. That's better patient care. Also, we have a better concordance of target lesions, which we have in a publication that's highlighted on the website, looking at a year's worth and 1,000 CTs. And that collaborative reporting, it's going to help minimize radiologist burnout. You're always in touch with somebody, even when you're virtual, and you're going back and forth, you're teaching them. And I think it's most beneficial to the students of radiology too. I ran across one today that trained with us is now in another department and saying how great this helped, because it's an active learning process. It's not a passive type of shadowing that some people call it, where you're observing a radiologist as they go through their images. I rarely found that helpful, but this certainly is. So those three areas: workless triage, the collaborative reporting, and the identifying of target lesions, improving the concordance with clinical trials, which we've published on and demonstrated that improvement.
Jane, has the course lived up to your expectations to gain clinical and research experience?
Definitely. As Dr. Folio was just saying, I'm getting direct exposure to clinical scenarios every day, and I've learned so much about diagnostic imaging and pathology. It's really been an invaluable experience. I also get to work directly with a physician on a project that's pretty innovative and has the potential to make great strides in the field. So that's exciting.
Dr. Folio, you mentioned an opportunity for young professionals interested in healthcare informatics to attempt an annotation challenge where their performance of pattern recognition on medical images can be posted anonymously like a video game leaderboard. Could you expand on that? Is it like the EyeWire effort to map the brain?
Yes, that's a good question. And I'm familiar with the EyeWire because I've introduced the presenter of that who's done TED Talks at various conferences. And yes, we get, as radiologists at NIH and similar to other academic centers, we're constantly getting emails for folks requesting clinical exposure or can I shadow you? And again, we don't have shadowing at NIH. We have research assistants or student internship program where you're actively participating. And so for folks that may not get these opportunities, which is most people, because I only get one slot every other year or so, and my funding's not always available for that. So there's virtual. What we've done with this course is to make it virtual since we've been teaching it for, I think, 5 years, but now making it online and publicly available is to have students that are interested that cannot come to NIH or other locations with annotation challenges. We have one on the website where you can go into the quiz section and download data of chest x-rays, for example, not related to clinical trials, but a pattern recognition kind of test of your ability. It's not a real test. There's no grades. Similar to, there aren't grades for how well a radiology preprocessor does, but there's comparative scores that you can look at. And again, not letter grades, but you can see how are your errors or how is your recognition of patterns compared to a radiologist. In fact, it could be a chest radiologist, a body radiologist, a non-fellowship trained or resident. And you can go in and annotate these. And now a lot of this is still under construction. And we do some of this in the Society of Informatics of Medicine hackathons, where we demonstrated, and there's a video link out to a hackathon that my team won in 2019 in Denver, Colorado, where we had 72 hours to build an annotation or to build a right from code, right from scratch, a program to show within 72 hours in front of an audience and judges to show how you can apply tools to help informatics and medicine. And ours was artificial intelligence and using a gamification concept that we called PAX-Man. So PAX like picture archiving communication system, but PAX-Man like the game. And it was an annotation game to go through CT anatomy. And then we created this. It was actually Alejandro from Columbia and Arseny from Marquette University, where and Michael Doe, my postdoc, and OG Marks from Florida Atlantic University, where we created this tool, presented it live. The audience was able to annotate different things like where's the gallbladder, where are the lungs, and a leaderboard was live and showing whoever was doing best would be up on top of that leaderboard. And the thing about leaderboards in video games is that they can be almost addictive, for video gamers, but an incentive for those to learn radiology. So we have it available to annotate chest x-rays. Where do you think the COVID pneumonia is compared to a TB data set that we have on the website? And you go to the website and then you can annotate them and submit the JSON files, and those annotations then can be compared with CAPA scores to ground truth radiologists. And then students can watch and see how they do on that leaderboard in comparison to others. So like EyeWire, well, we're not building, so we're not mapping the brain. And I think EyeWire is a brilliant crowdsourcing program, which I take as a compliment to be compared to that, but similar that anyone can go in and download the data, annotate the data, submit it, and then compare and see how they've done compared to others. And yes, I think the crowdsourcing can create some, maybe not the highest quality machine learning data, but if you take the top folks, and some of those being radiologists or trainees, could then be crowdsourced and produce heat maps as to where COVID pneumonia is distributed more peripherally and tuberculosis more in the right upper apex. So I think there is a lot of potential to that type of approach. And I think the leaderboard, it's not active yet because we've only got a few participants. I'm in second place. Because I'm comparing myself to a world expert chest radiologist. So there's a competition there to try to beat me to be in second.
Jane, do you feel being virtual has been as efficient as actual physical interaction?
I think so, yes. Obviously, I miss face-to-face interactions, but we've created a really efficient virtual workflow, and I get to stay safe in my home doing exactly what I would be doing in the clinical center anyways. I've learned that unlike interventional radiology, diagnostic radiology is primarily about image interpretation, so it really lends itself well to remote work and learning. And the work times are really flexible with my schedule, which I think results in an optimal quality of life. And also, because I get to avoid commuting, I can dedicate more of my time to focusing on the mission, which is a big plus. One con, I guess, is that I do think that there's increased time that I spend with the PACS, since neither the laptop I was issued nor my home internet connection is as powerful as what the radiologists and prior RPs were able to use in the clinical center.
Dr. Folio, how does this workflow integrate with residents?
That's a good question, and there's been some debates on that in not the literature, but some of the meetings, and this is a good place to get that straight. It's first of all, it's completely separate, so it's not integrated with residents at all. I don't think it's been out long enough, at least not at NIH, and I don't know of anywhere where it is. Residents' workflow is already established. The residents are picking up the exams before the radiologist, and probably in a similar manner. But the radiology preprocessors, it would be, it's never even crossed our mind to do that. They're two separate things. It's no longer a study. It's just a better way to do business, but not mixed with residents. So they're two completely separate things. Residents learn a little bit about clinical trials and measurements, but the RPs focus on the PACS tools and the multiplanar and the bookmark table, which are the target lesions that the oncologists are following. So that's completely separate for us anyway. And I see that being the way for the next few years. So completely separate. But it is a collaborative workflow similar to residents and their instructors, their professors, and in private practice. Since in private practice, the radiologists by themselves, also being virtual, don't have the benefit of having residents. So but they're used to this collaborative kind of discussion and teaching because there's so much to think about. And when you do have radiology preprocessors, it can be an academic type parallel where you could be instructing them on what they found because they don't have the background. They just have this course. So it's a constant learning. It's a lot of learning, but they're not bound to the same responsibilities as a resident. The resident has to be precise, and there's levels of expectation with residents. Whereas RPs, the expectation is just to have measurements, and then we import what we accept into the report. And generally after, I might have mentioned this before, after 20 hours of training on the online course and 50 CTs, a radiology preprocessor is already helping the radiologist and finding the target lesions and making the reports more concordant. So they're two different things, and they're completely separate.
Jane, are there times you feel over your head that there's too much to take in or be responsible for?
I feel over my head every day, but Dr. Folio, prior RPs, and definitely the course have prepared me well to perform the task at hand. I think it's important to remember that everyone has to start somewhere. And there are a variety of educational and experience levels of prior RPs, including undergraduate students, medical students, physicians just out of medical school, and then residents and fellows training other specialties such as oncology or infectious disease. Dr. Folio mentioned an analogy with beginner student pilots that I thought was helpful from when he was a flight instructor, where the first time a student pilot takes the controls, they're overwhelmed with the variety of inputs to maneuver the plane most effectively. But most can turn the plane left and right and up and down. And this is all with the instructor pilot right there, providing constant feedback over many sessions. Not dissimilar to how the radiologist provides constant feedback to the RP on every step. So Dr. Folio says that RPs are not aiming to be commercial pilots or radiologists. They're aiming to get exposure to the environment while learning quickly and collaborating in a team where they know their boundaries. Also, when we RPs miss findings, we're reminded that RPs are not responsible for finding everything, as ultimately that is the radiologist's duty. Dr. Folio avoids dependence on RPs, much like an instructor pilot would not let a student pilot fly without observation.
I could actually add to that.
Sure.
And Jane, you've been watching this too, an abstract that we just submitted. We had an extended abstract opportunity with the Association of University Radiologists coming up in May this year, where we took it further than just the student pilot, and that was well put, Jane. I don't think I could have put it as well, where we related the workflow of some private practices that have 6 radiology preprocessors, or what again they call them scribes sometimes. And I related that workflow to the AWACS, or Air Reconnaissance. They're pretty much the Air Force planes that have a radar dome and 24 people in the airplane doing combat control, where airmen in the Air Force, active duty, just out of high school with several months of training, go and learn a very specific task on a radar. And then each of them takes 6 quadrants in an area. Then those airmen, who are pretty much not even college students, they may be in college, or the courses they're taking for radar may count for college, but 18, 19-year-olds being mentored in that part, then taking their sector of the radar screen, and when they find an anomaly similar to a radiology preprocessor, they move that up to a tech sergeant, and then they triage it to a captain or a lieutenant that then takes all that information and puts it up to one mission commander, which is a lieutenant colonel or a colonel in the Air Force. And then this triage of data is similar to how a radiology preprocessor could be getting together ultrasound data, the measurements for an OB ultrasound, or the carotids or the legs and vessels and taking all the measurements, which the radiologist doesn't need to get involved with the measurements. We just get a big picture of what the change is. Are they narrowed in this area? Or another preprocessor working on mammography or finding incidental findings. So in a private practice where they're dealing with MRI, ultrasound, nuclear medicine, each one can have their own specialty and have this kind of collaborative reporting, very similar to AWACS. Again, over their heads, but knowing their specific task and in relating that information up. So kind of adding to what Jane said.